Osteoarthritis is a degenerative condition that affects hundreds of thousands of Americans. It can involve any joint in the body, but one of the most common joints it affects is the knee joint. Now, the knee joint is supposed to be lined by a very smooth cartilage that we call articular cartilage. When that smooth lining wears away, you get down to a rough surface, which is actually the bone. And that's why you hear many people refer to arthritis being bone on bone. That bone-on-bone condition causes swelling in the knee, it causes stiffness, as well as pain. As orthopedic surgeons, that's our goal, to treat those symptoms. So patients may report pain, particularly when getting up out of a seated position and starting to walk, also getting out of bed in the morning. And most of the time that pain is localized to the actual knee joint itself. Another thing that patients experience is swelling in the joint. So their knee often feels full and they have difficulty bending it. So ultimately they lose motion in the knee. So initially when a patient presents to my office and we're suspicious of an arthritis problem, the most basic way to diagnose that is not only physical examination, but also a routine X-ray. And in that X-ray I'm looking for findings of narrowing of the joint space. And we can often see what we commonly refer to as a bone-on-bone situation. Once we make the diagnosis of osteoarthritis, then we have a discussion about how best to treat it. Now, there's multiple ways you can go about doing this, but we always try to initially start with conservative management. That might include medication, which we commonly refer to as anti-inflammatory medication. Patients also are now taking supplements for this. There's many times where medication is not enough, and then we have to go on to other conservative measures, which in my hands routinely consist of injection therapy. Now, there's two common injectates that we do put in the knee. One most people have heard of, and that's cortisone, and that is administered through a needle and just injected in the knee joint itself. The other is what I call a lubricant injection, but basically that lubricant is placed in the knee also via a needle, and it acts as a lubricant, a friction reducer, and a shock absorber in the knee. If patients benefit from that, that can be done every 6 months as needed, and it's absolutely no harm to the knee joint itself. So a very attractive alternative for people that don't respond to medication or cortisone. Physical therapy can also be a very valuable modality in treating osteoarthritis of the knee. With therapy, you can strengthen the muscles around the knee, thereby increasing the ability of the muscles to support the knee. And also through therapy, you can help regain some of the motion that's lost through the arthritis process. So oftentimes after treating osteoarthritis conservatively, the patient does not receive what we call a satisfactory pain relief. And after exhausting those conservative measures, it's often necessary to talk about perhaps approaching the problem through surgical alternative. That surgical alternative, when you're talking about arthritis of the knee, can really consist of two different options. One option, which most people know of, is a total knee replacement. A total knee replacement involves basically taking away all the arthritis in every part of the knee, cutting it away and replacing it with a prosthesis. That procedure itself has been around for many, many years and has a great track record in terms of improving patients' pain level and their quality of life. Similar to a total knee replacement, we have something we call a partial knee replacement. And the difference is that instead of replacing a patient's entire knee, we're replacing just one part of the knee. The knee actually is one big compartment. However, it consists of three very distinct subcompartments, I will call them. So you have an inside part of the knee, an outside part of the knee, and underneath the kneecap part of the knee. In many individuals, only one part of the knee is affected by the arthritis process. If only one part of the knee is affected and they can localize their pain to that particular part, then they are candidates for what we call partial knee replacement. In partial knee replacement, I basically remove just the arthritis in that one specific part of the knee and then resurface it with an implant using the same materials that are used in a total knee implant, but the implant is specific to that compartment of the knee. When I do partial knee replacement, I utilize a technology that uses robotic assistance. Now, that technology has been around for about the last 5 years or so, And what that helps me do is accurately place the implant that I'm putting in the knee. So I can template the entire surgery out before I even do it, and then during the surgery I can see how the implant is sitting in the knee, as well as the stability of the knee throughout the patient's range of motion. One of the major differences of partial knee replacement versus a total knee replacement is that because we are able to retain most of the patient's native knee in partial knee replacement, patients typically will report that their partial knee replacement actually feels more like their native knee. And in my practice, I do many partial knee replacements and total knee replacements, and I would say that indeed, patients do feel like they have a more natural knee when they have a partial knee replacement. The recovery is also somewhat faster with partial knee replacement versus total knee replacement. It's not uncommon for a patient to come in my office at only about 3 weeks out from partial knee replacement and barely be walking with any type of assistant device such as a cane or a walker. The bottom line is, though, we really don't have any restrictions following partial knee replacement or total knee replacement for that matter. We like to mobilize the patient as fast as possible, meaning put all your weight on the leg that you would like to, and also start bending your knee as early as possible. So really the recovery is often left up to the patient as far as how fast they want to go. My name is Seth Baublitz. I practice as an orthopedic specialist of Central Pennsylvania. Our office is located at 2150 Knoll Drive in Lancaster.